Good afternoon. Good afternoon. It's Dr. Hassanein. I'm from San Diego. I'm actually recording this talk for Dr. Hisham Ayub and your distinguished faculty and distinguished meeting in Marsa Matruh. I wish I would have been there, but uh, I am not in Egypt these days, and so Dr. Ayub asked me to give a presentation about where we are with the care of liver patients, particularly patients who have cirrhosis. Over the last 10 years, we established a program called HALO, which stands for Health and Liver Optimization. And what we will talk about today is when we have patients with cirrhosis and end-stage liver disease, how we can assess them and stage the functionality of the liver. We know they have cirrhosis, so by histology, they are cirrhotics. And by clinical presentations, we need to subclassify these patients who present with cirrhosis to know the prognosis and to know how to help them to stay alive and not to succumb to their disease. So over the next few slides, 30 minutes or so, we will be talking about where we are with the new classifications and what we are doing these days to keep our cirrhotic patients well and alive. All of us know these pictures. That's a normal liver, looks nice. When patients have cirrhosis, they have irregular surface, a lot of nodularities. There's a lot of increase in fibrosis, and we know within the first 10 years after patients reaching the cirrhotic stage, a lot of our patients, 3 to 4% per year, develop liver cancer. So now that's where we are. We want to keep all our patients close to normal, and we want to avoid the patient moving from cirrhosis to develop cancer. Any liver disease, whatever the disease is, viral hepatitis, alcoholic liver disease, NASH, autoimmune hepatitis, whatever the liver disease, the liver goes from normal to a stage of chronic hepatitis. And the stage of chronic hepatitis is chronic inflammation of the cells, around the cells or around the different cells of the liver due to the etiology of the disease, whether it's hepatitis B or C or any viral hepatitis, or is it related to alcohol or non-fed or non-alcoholic steatohepatitis, which we call metabolically associated steatohepatitis these days. You leave your patient 20, 30, 40 sana, what's going to happen? They're going to develop into cirrhosis. Anytime they develop into cirrhosis, they run the risk of cancer. Although nowadays we see patients in the late stages of chronic hepatitis developing liver cancer, particularly in hepatitis B, even with normal liver, chronic hepatitis B can lead to cancer. With MASH, we see people, even without cirrhosis, developing liver cancer. So why all this is happening? You can see here the basic concepts of fibrogenesis. There's a cascade of events. So alcohol, ASH, obesity with MASH, hepatitis B, hepatitis C, chronic drug toxicity, other cryptogenic diseases, venous obstruction, cholestatic liver disease, PBC, PSC, anything that happens that affects the hepatocyte leads to inflammation. And the inflammation leads to influx of circulating cells that release mediators. I call it the fire. And you can see here the drawing showing a fire. That fire, inflammation in the liver, makes the hepatic stellate cells active. And these cells are usually quiescent. Once they are activated by all the inflammatory and circulating cells and the release of cytokines and certain mediators, they become active. Once they become active, they develop cascade. They change in how they look, and they start the process of fibrogenesis and extracellular matrix synthesis to develop fibrosis in an attempt to heal the liver. عشان liver يتحسن. In an attempt to heal the liver, fibrogenesis occurs. Now, a number of mediators has been identified, and in basic research, we can even see that these active stellate cells starts calling on the bone marrow to send more fibrocytes. It starts calling on other blood cells to come infiltrate the liver so they can heal the liver fast. The process of healing is fibrogenesis, leads to fibrosis with extracellular matrix deposition, and that's what leads to cirrhosis, and if it continues, leads to oncogenesis and development of cancer. So if I want to approach AIN liver and we want to control the fibrogenesis process, we need to start from the left. Stop the alcohol, treat the hepatitis, control the drugs, control the metabolic diseases, control the obstruction, control the cholestasis, so I can stop the inflammation, the activation of stellate cells. Because we learned that if we can avoid all these things, the active stellate cells can go back to a quiescent state and actually do the opposite and starts breaking down the fibrous tissue. So why this happens? Because we know that the liver has regenerative capacity that not matched by other organs in the body. Hepatocytes rarely divide, but can reproduce in response to a appropriate stimulus. Example, you do a hepatic resection, the liver grows again. Usually it restores itself to almost within 5 to 10% of the original weight. The hepatic injury or the partial removal leads to both systemic and local release of growth factors. Regenerative capacity can go forward, although it could be compromised by the pre-existing degree of liver damage. If I split a liver, a healthy liver, it grows very fast. If I split a advanced fibrotic liver, it doesn't grow as fast. So excessive damage, there's a point of no return, and that's what we are trying to avoid. Clinically, بنقول etiologies of liver disease. أي حاجة من الetiologies دي leads to chronic liver disease, progression from fibrosis level 1 to 2 to 3 and 4, increasing fibrosis, you get to the point of cirrhosis, still the liver functions are intact. We call it compensated liver disease. Now, certain developments or complication can happen because of the progression of fibrosis, ascites, portal hypertension, bleeding, hepatic encephalopathy, hypoalbuminemia, sarcopenia, jaundice, coagulation problem, hepatopulmonary syndrome, portal pulmonary hypertension, hepatic cardiomyopathy. All the things develop as the progress in fibrosis continues, leading to a stage that we call decompensated liver disease. A decompensated liver disease can cause death unless we get this patient to transplant. And at any time, whether before decompensation or at the level of decompensation, the patient can develop cancer. Now we identified another level of decompensation, not the standard decompensation by type. No, we now say the compensated liver disease can have a precipitating event, although it is very stable, and the patient is at home doing the regular daily function. They can get an extra acute liver injury, such as drinking, binging on alcohol, or an acute viral hepatitis E co-infection, or a hepatitis D co-infection, or taking a drug that induces liver injury, or any condition that leads to liver ischemia, that's further leads to a progression to infections and acute insult for the compensated patient, or the decompensated patient leads to further decompensation. That's what we call these days acute and chronic liver failure, because these patients now have more resistant hepatic encephalopathy, more resistant ascites to treatment, more hyponatremia, they start getting into hepatorenal syndrome, more severe coagulopathy, worsening jaundice, and they die. So there is compensated cirrhotic that by time they get decompensated, and then if they get an acute insult, they can get the acute and chronic decompensation or acute and chronic liver failure. So to summarize all this in this big slide, the precipitating events, taking excessive alcohol intake, DILI, which is drug-induced liver injury, and acute viral hepatitis will take a patient from a pre-cirrhotic to a cirrhotic stage. The cirrhotic stage can last 10, 15 years. With an acute on chronic, with an acute event, you can lead to acute and chronic liver failure with acute decompensation that leads to multi-organ dysfunction. That's what we call acute and chronic liver failure. Means not only the liver now is failing, the kidney starts to fail, then the next thing is encephalopathy and brain failure, then coagulation failure, then lung failure, and the patient now in multi-organ failure, and they die. So now, you can see here a new way of looking at liver cirrhosis. So now we subclassify cirrhotics into different groups. CC means compensated cirrhotic, asymptomatic stage with no signs of clinical complication, and they are stable, these are the regular cirrhotics. When they get into decompensation, we have two types. We have stable decompensation and unstable decompensation. So stable decompensation, non-progressive decompensation, they have the ascites, encephalopathy, Gilek fil ayada. You control the ascites with diuretics, you keep them out of encephalopathy, there's no further deterioration, and they can stay like this for years. An event happens that leads to unstable decompensation. Now, the ascites is worsening, the response to diuretics is not there anymore, the hepatic encephalopathy is getting worse, but still they didn't get into the multi-organ failure. And why these classifications are important? Because a compensated cirrhotic, the mortality, the 1 year mortality less than 5%. If they are stable, decompensated, so they decompensate but stable, mortality is around 10%. If they are unstable, the mortality goes to 35%. Now, there's the stages of a new bacterial infection, new event that leads to an ACLF, acute and chronic liver failure, which are type 1, type 2, and type 3. When you look at type 1, the 3 months mortality is 40%. And type 2, the 3 months mortality is 50%. And type 3, the 3 months mortality is 80%. So there's a phase of progression from unstable decompensated cirrhotic to pre-ACLF, then they go into the ACLF grade 1 to 2 to 3, and that's what, as clinicians, we need to keep our patients to the left as much as possible. They show up in your office and the clinic and they have compensated cirrhotics. You want to keep them at the level of compensated cirrhotics with a mortality less than 5%. You don't want them to progress through these stages. How are you going to do this? By handling the precipitating events. So when you look at, can I regress a compensated cirrhotic? I do regression in the fibrosis. Yes. We do this with Hep C. We do it with autoimmune hepatitis. We do it with fatty liver. We do it with a number of etiologies. We do it with alcoholic liver disease once they stop the alcohol. When they get into the first decompensation, very important, I have to eliminate all the etiological injuries. And I start improving the portal pressure, preventing systemic inflammation, stabilizing the hemodynamic changes to prevent further decompensation and death. So these are very important concepts. What my measures are. كلنا عارفين ال CTP classification, اللي هو Child-Turcotte Pugh assessment, and severity of cirrhosis. And some of us like it, some of us don't like it, but in any case, there are 2 clinical parameters, 3 lab parameters. Encephalopathy ascites, clinical, prothrombin time or INR, serum bilirubin and albumin, serum albumin, these are the labs. And now, when I talk, if I talk with any of you and say hepatic, I say, what's that you tell me, I have a patient with cirrhosis. The next question, what is the child classification? You're going to say child A. Now we say child A 5 points, different than child A 6. Child B 7 is different than child B 9. Child C 10 is different than child C 15. Because why this is important? لما العيان بتاعي بيجي لي العيادة and they are child B 7, I can pull them back to child A 6 and 5, and so forth. When they are child C 10, my goal is to pull them back to child B, stabilize them, then take them from child B to child A. Very important classification. Start using these numbers. And then we have the MELD. خلوا بالكم, the MELD is an equation عشان ندي بيها organs. It doesn't tell me too much about the severity of the liver disease, because the MELD can change if I take care of the etiology of the liver disease. Like the MELD is bilirubin, prothrombin, creatinine. The equation is well known, and the scores are well known. It can go from as low 6 to high 40, and each level indicates امتى العيان أو what is the survival chances. And you can see here, if the MELD is above 40, the 3 months mortality is 100%. لو الميلد between 30 and 39 is 80%. لو الميلد is 20 to 29 is almost 75%. And if the MELD is less than 9, it is 4%. فاحنا هنا in the US, we use the MELD to assign organs. يعني لو عندي 2 patients waiting, they are similar, and one, their MELD is 35, and the other one, their MELD is 25, of course, the organ, when it comes, it's going to go to the 35. We rarely transplant patients that their MELD goes above 40 because they don't do well. Anyway, people abused the MELD score. So they talk about it as if, this patient is going to die tomorrow or next week or next month. Okay, now we have a third classification called the Cliff C. And the Cliff C of organ failure score came from the Cliff Consortium, which is the Chronic Liver Failure Consortium, and they established the organ failure scale, and they look at the different organs, the liver, the kidney, the brain, coagulation, circulation, respiratory. They defined what defines failure. And these are the group in Europe that came with the classification of acute and chronic liver failure. And that classification helps you to identify if the patient has ACLF or no ACLF. And then they have 2 scores. The score Cliff C, ACLF score, will Cliff C acute decompensation score, AD score. And why they did this? Because to differentiate between the chances of mortality within the first 3 months. And you can see here that they use this classification to decide about who gets a liver transplant, who gets continuous treatment because they will get better, and who it's futile that you keep resuscitating these patients because you are sure that ACLF stage 3, if they are not transplant candidates, you have there is enough data to say that they will be 0% survival in 180 days. Okay. So what are my goals in managing my cirrhotic patient? In compensated cirrhotics, I need to treat the etiology. Now, after alcohol and they're already cirrhotic, if they are already cirrhotic, they can actually go to F3. If I have hepatitis C, and we saw this quite common in alcohol and hepatitis C, and now we are seeing it in MASH, and we see it on autoimmune hepatitis. If you control the disease, you can pull the patient from a full-blown early cirrhosis by histology to an F3 and even an F2. So first step, find the etiology and screen the patient and treat it. خلينا نصحين. We don't think that the patient has one etiology. He might have hepatitis C, but he might be drinking alcohol. He might have hepatitis C, but he has metabolic syndrome and metabolic fatty liver. He might have hepatitis C co-infected with B. So to a certain extent, there's a primary liver disease that you might call hepatitis C, but there's other, you have to figure out if they have other liver problems or not. Because when you approach a patient like this and you want to have an impact عليهم, you have to treat every liver injury. Hepatitis C, fatty liver, stop the alcohol, stop the medications, and the herbs that might lead to more liver disease progression. Okay, type, لو هم cirrhotic already, what do I need to do? I'm treating the etiology, number one. Number two, I have to screen and prevent them from decompensating. The screen يعني endoscopy, ما استناش انه to bleed. I do the endoscopy, I find the varices, I treat the varices. Okay, whether we are using carvedilol or beta blockers, or if we are doing banding or sclerotherapy or TIPS. I'm doing ultrasound and I'm screening for cancer to find the cancer very early. I'm giving them the vaccines so they don't get super infection by hepatitis A or B and so forth. And actually other vaccines, مش عايزهم يجيلهم pneumonia, مش عايزهم يجيلهم influenza, مش عايزهم يجيلهم COVID. So all these are tests to do for a cirrhotic to prevent any complications. لأن أي complication can take the compensated cirrhotic to decompensation. Prevent complication. Prevent أي factor that can lead to acute and chronic liver injury. Alcohol use, any viral hepatitis, or any drug-induced injury. Okay? Avoid any drugs that can worsen the intravascular volume. Excessive diuretics. Okay? Certain blood pressure medication, and so on. Preserve the kidney. لو liver تعبان, if you have cirrhosis, as I always say and teach my students and my residents and fellows, no liver patient dies with a good kidney. The kidney has to shut down for the liver patient to die. So make sure you never lose the kidney. Okay? Don't push the patient over the edge and you lose the kidney. Prevent the first variceal hemorrhage. Don't wait to bleed to react. No. Find the patient varices, deal with it. Beta blockers, we talked about carvedilol, propranolol, nadolol. But carvedilol now became our main drug because it helps to control portal hypertension. And of course, as we said, banding and so on. So reduction in portal pressure with non-selective beta blockers or carvedilol can also prevent development of ascites and decompensation. Very important point. No alcohol, total abstinence. viral hepatitis. If they have hepatitis B, you have to maintain them on treatment. If they are hepatitis A virus negative, give them the vaccine. If there's antibody for hepatitis B surface antigen is negative, give them the vaccine. So if you're going to do chemotherapy or immune therapy for these patients, make sure that hepatitis B never reactivates. Okay, drugs, medication that affects the liver. More than drugs can be used safely, including those that are potentially hepatotoxic if you don't exceed the doses. For example, Tylenol, paracetamol. If you don't exceed the 2-3 grams, you can use it. Statins are safe. And if you have any issue with any medication, go to this website, livertox.nih.gov. This would tell you if any drug is hepatotoxic and how you can use it. Okay, but we know we don't want to use NSAIDs, non-steroidal anti-inflammatory drugs. We know it shuts down the kidneys. Vasodilators, our patients tend to have a low blood pressure. Non-selective beta blockers and carvedilol should not be used if there's a significant drop in the mean arterial blood pressure. General health recommendation, food and weight. So I always tell my patient, no alcohol, don't gain weight, but maintain your weight, eat protein. Very common, doctors tell the patient don't eat protein because of encephalopathy. No, most of our patients are protein malnourished. Eat protein. Statins are not contraindicated. Give them their immunization for the influenza and pneumonia and COVID, and make sure that if it's age to screen for colon cancer, you do this. Women for mammograms and pap smears. Now, second, ultrasound, find ascites. Even if it's minimal ascites, you start thinking about what I'm going to do with this ascites. Salt restriction, simple diuretics. We know that most of the ascites are responsive, and that's the new classification we use for ascites, responsive to treatment. They recur at least 3 times within 1 year, despite sodium restriction and adequate diuretic dosage, adequate diuresis, and refractory, which is ascites that you cannot mobilize it by medication, and now you need to do large volume paracentesis. So to a certain extent, this is our classification. ليه بتكلم عن النقطة دي؟ لأن الألبومين albumin infusion showed significant effect on ascites, بالذات قبل ما نوصل للرefractory ascites. We all know this drawing. We all know this pathophysiology. Portal hypertension, we increase systemic inflammation, بيزود splanchnic and systemic vasodilation, blood pressure بتاع العيانين بيبقى واطي. There's decreased effective arterial blood volume, activation of the neurohormonal systems, sodium retention, water retention, renal vasoconstriction, decreased renal blood flow. All these are the things that leads to more ascites, hyponatremia, and acute kidney injury leading to hepatorenal syndrome. So anytime you have an infection like SBP or an injury that leads to acute or chronic liver failure, all this cascade moves faster. So albumin became an important point. Why? We use albumin for oncotic function, but albumin has a lot of other functions that showed to be very helpful in our patients. It has an antioxidant effect. It transports a lot of medications, and it binds a lot of toxins, decreases inflammation, stabilizes the endothelial, and it has an anti-thrombotic effects. So we use albumin to help in controlling ascites and hyponatremia, and to maintain the effective arterial hypovolemia. We use it in systemic inflammation to decrease oxidative stress. It binds endotoxins. It helps the activation of neutrophils, and in patients under certain indications that we all agree to. The albumin molecule is a complex molecule with a lot of receptors. These receptors binds toxins and get them and help in the helps in the developing or helps in ameliorating all the issues that we see in our liver patients who characteristically have low albumin in their serum. So there is albumin in healthy individuals. It maintains our oncotic pressure, but it has other than oncotic pressures, has non-oncotic properties, transport, detoxification, antioxidant activity, endothelial stabilization, hemostatic effects, and immune inflammatory response modulation. ايه مشكلة العيان decompensated؟ الالبومين بتاعه structurally is damaged, and that in itself makes that albumin is less effective than the albumin of a healthy individual. So what can we do with this? We use the albumin in many different ways these days to help us in cirrhotic patients. We use it to decrease the inflammation. We use it to maintain the intravascular volume and avoid the hypovolemia with all the cardiocirculatory dysfunctions. And we use it in helping immune modulation. So here's a study that Paolo Carciani from Italy have published in the Lancet, showing clearly that when you do standard treatment plus albumin, the survival, the 18-month survival is significantly different than just giving standard care without albumin. So this is a very important study that showed us that managing patients who have ascites with standard therapy, diuretics and food and all this and salt restriction and whatever we do, if we add the albumin, we have a significant improvement in the incidence of doing paracentesis. لما بيبقوا على الالبومين, much less paracentesis. When they are on the albumin, much less chance of refractory ascites. And we saw the most important data, which is when they are on the albumin, their survival is better. So the role of IV albumin is in the acute and short-term versus long-term. Now we're talking about a new concept, long-term treatment using albumin to keep patients out of the hospital, decrease the chances of decompensation, decreases the chances of getting into more complications. And at this point, this has become a standard care in Italy. And now in the US, we are doing a study, which we have done, giving patients IV albumin as outpatient so we can prevent them from decompensating and getting inside the hospital. And we are waiting for the final data to be published. So use of human albumin infusion for cirrhosis-related complications. We already know that in hepatorenal, in patients with SBP, in patients with high volume paracentesis. And nowadays, there's new data about it decreases hepatic encephalopathy. We know it improves hyponatremia, and we know now that it might help with muscle cramps, and it might have a role in septic shock in liver patients. And there's a question about, we need more data about its role in acute decompensation. Keep your minds open about the albumin infusions. What about systemic infections? Any cirrhotic بيخش المستشفى, there is an infection. 1 out of 3 hospitalized cirrhotic patients, they are there because of a bacterial infection. 1 out of 2 cirrhotic patients with GI bleeding, they have an infection. Okay, so to a certain extent, patients with cirrhosis, with decompensation, infection is a big role. And we have seen this in SBP, UTI, respiratory cellulitis, spontaneous bacteremia that we always call it translocation. And you can see here between SBP and UTIs, almost 50% of our patients with cirrhosis, they get to be admitted to the hospital. The significance of bacterial infection cirrhotic, the infection can lead to acute and chronic liver failure, تدخلك في ACLF, acute kidney injury, more coagulopathy and thrombocytopenia, increase the portal pressure and variceal hemorrhage, and septic encephalopathy, septic cardiomyopathy. And that's where we come to the point of acute and chronic liver failure from ACLF 1 to 2 to 3. And once you get to 3, the mortality is significantly high. Which patients with cirrhosis are most susceptible for infection? You have certain prediction. Child C أكتر من child B أكتر من child A. Low serum albumin أكتر من العيانين اللي عندهم normal serum albumin. عيان بيجيله hemorrhages, variceal hemorrhage is higher chance of infection. So patients who already got SBP, they are telling you, we're going to get infections. And we have learned that if the acidic fluid is less than 1.5 grams per deciliter in the acidic fluid, that these patients would put them on prophylactic antibiotics. Although now there's data showing that, with prophylactic antibiotics, we are selecting certain bacteria to grow, and we start to see more gram-positive bacteremias in these patients. So, bacterial infections are a significant cause of morbidity and mortality in cirrhotics. Screen for infection, ما تستناش culture to be positive. You suspect an infection, start treating them. And any signs of deterioration in a patient with cirrhosis, make sure they don't have an infection. That the classic antibiotic is ceftriaxone, 1 to 2 grams IV every 24 hours. That's your first line of therapy in patient with SBP, and we give it for 5 days in most of the patients. And we know that with SBP, we have to give them the albumin over the first 3 days to improve their survival. Okay, so the key message here is early recognition allows preventive measure. لو انت بتفكر ايه اللي هيحصل للعيان بتاعك، بتبتدي تاخد الخطوات من الاول بدري بحيث ان انت prevent them from deteriorating. Cancer screening, very important, with ultrasound alpha-fetoprotein. Viruses with endoscopy. Recognition of encephalopathy and putting them on lactulose and rifaximin, making sure there's no infection. Finding ascites early, putting them on low salt, gentle diuretics. If you need high dose of diuretics, support them with albumin. Lifestyle and nutrition counseling for the low salt, high protein diet. Night snacks is very important. Early intervention when patient decompensate is very important to prevent further decompensation. In conclusion, cirrhosis can be asymptomatic. Find your patients, screen them, and follow them closely. Screening and surveillance of life-threatening complication can allow early recognition and preventive strategies. Individuals with symptomatic cirrhosis and liver cancer should be managed and considered for liver transplantation. And very important that we develop the skills and we talk to the other doctors and we be the dedicated group of doctors to care for patients with cirrhosis. That's the concept. That's what we preach, and that's what we do in Halo to maintain a healthy liver as much as possible. And you can always see that, and we have the experience with patients with cirrhotics living for 20, 30 years till they develop the cancer. And nowadays, maybe in the future, I will give you a talk about liver cancer and the new management, because now our average liver cancer patient is living 3 to 5 years in the US. Thank you very much. I wish and I hope that I would be joining you for Marsa Matruh, but at least I hope that this talk opens your mind to the concept of not giving up على العيان اللي عنده cirrhosis. We can help these patients, we can give them a good life with good quality of life, with simple close monitoring and simple management. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.